Hello, good morning or good afternoon, depending on where you are around the world, and welcome to our webinar on reducing maternal, neonatal, and infant mortality as a means to achieving sustainable development goals in Africa. To introduce myself, I am Alexandra Brown, Product Manager here at AIDF. Thank you so much for joining us today, and it's a pleasure to welcome so many listeners. We have received over 500 registrations for today's webinar, which is a testament to our excellent speakers sharing their thoughts on such an important topic. Please be aware this session is being recorded and a link will be emailed to you in a few days' time for your records. Please don't worry too much about making notes, as you will have all this information with you shortly. For those of you who are not fully aware of us, over the last 14 years, AIDF has hosted high-profile summits across the world with the aim to provide a platform for independent debates, knowledge exchange, and establishing long-lasting partnerships that will improve efficiency and effectiveness of aid and international development. Through this network, we have been inspired to use our platform and digital community to promote greater awareness around the challenges to achieving sustainable development goals, especially in relation to maternal and infant health. Today's webinar takes place ahead of our third annual Aid and Development Forum in Nairobi at the end of this month. The event unites key UN agencies, NGOs, investors, and government officials to explore policy and project updates, best practice, and innovation to improve humanitarian aid across sub-Saharan East Africa. For now, this brings me back to today's webinar, looking at reducing maternal, neonatal, and infant mortality as a means to achieving sustainable development goals in Africa. Over the next hour, we will explore the following issues and more, including using emerging technologies for improved diagnostics and treatment, promoting gender-sensitive health systems, policy and practices, both nationally and internationally, and traversing the gap between communities, health systems, and governments. You can join the conversation at any point using the hashtag AIDFwebinar and stay up to date by following us on Twitter. You can also submit your questions using the GoToWebinar question box on the right-hand side of your screen. So, without further ado, I would like to welcome our speakers, who I know come equipped with a wealth of knowledge and experience on this topic. Unfortunately, due to unforeseen circumstances, Mr. Konom from the United Nations Population Fund will not be joining the webinar today. However, we have two experts who, as I mentioned, are equipped with a wealth of knowledge and I'm sure will provide a very interesting debate for us. Firstly, we have Dr. Edwin Lutomia Mangala, who is a health specialist for maternal, newborn and child health at the United Nations Children's Fund. Edwin will be followed by John Nyamu, National Coordinator at the Reproductive and Maternal Health Consortium-Kenya. Each speaker will take a few moments to present their views, following which we will take questions from our listeners. And with that, I'd like to hand over to our first speaker, Dr. Mangala. So Edwin, I will be shortly unmuting you and giving you control of the screen so you can start your presentation.
Thank you so much, Alexandria, for that introduction. And thank you also for inviting me to be a panelist on this webinar. I'm quite privileged to have this chance to be able to share a few thoughts with colleagues in terms of the sustainable development goals and how this relates to reduction of maternal and newborn deaths, more so in developing countries. Yes, so my presentation today is centered around improving quality of care for women and newborns. And I'm looking at the interface of community, facility, and district level interventions with a specific focus on what the evidence is telling us in terms of what works. And the presentation is largely based on the work of Buta and colleagues, who in 2014 published a a journal entitled Approaches to Improve Quality of Care for Women and Newborns, Conclusions, Evidence Gaps, and Research Priorities. I just want to give a very quick background on this in terms of the progress in reduction of maternal and newborn deaths from the era of the Millennium Development Goals to the current Sustainable Development Goals. Worldwide, it is accepted that there's been a significant reduction in the number of women and newborns who are dying around the time of birth by close to 50%. But much of this progress has mostly been in Eastern Asia, Northern Africa, and Southern Asia. If you look at most of the least developing countries, especially in sub-Saharan Africa, the reduction wasn't as expected. And much of this is being pointed to the fact that although there was an increase in access and coverage of health services, there is still a gap in the quality of maternal and newborn services that are provided both at the community and at the health facility level. So my presentation is going to focus much on that. I'm going to be as brief as possible to be able to give time at the end of the presentation for discussions so that we can be able to look at possibly areas for improvement in terms of filling the gaps. So looking at the community level, there has been much interest in community programs, mostly because of a critical shortage of trained healthcare workers in developing countries. And so this has led to a focus on task shifting, or basically being able to empower community volunteers to be able to provide some basic maternal and newborn services at the community level. And looking at the evidence on what has been able to work so far at the community level, we have home visitations, community mobilization, women support groups, training of community health volunteers and traditional birth attendants. These have shown significant and positive impacts on maternal and newborn health outcomes. Although with the traditional birth attendants, it's quite still a sensitive area in terms of, I know there are regions in the world probably that are still quite sensitive or reluctant in terms of bringing traditional birth attendants on board. But there are good lessons that are coming from other regions in terms of reorienting traditional birth attendants to be able to act as referral agents and in the process to be able to boost skilled birth attendants. Secondly, in terms of looking at the evidence, generation of funds for transportation have also had an effect on access to maternal and newborn care. And in this, we are basically looking at being able to support community groups, community persons, to be able to have transportation arrangements that can be able to aid referrals during obstetric and newborn emergencies. Key issues for further discussion, and probably that other members who are listening in can be able to contribute to, just to generate a bit of debate around it. Incentives to community programs, it's still outstanding in terms of getting the right approach or strategy to ensure sustainability of these community programs. Also, understanding factors affecting the sustainability and cost effectiveness of these community interventions when scaled up. There's very little evidence that has been generated around this area. And also better understanding of how referral interventions work especially looking at formal monitoring and evaluation of referral interventions. Then lastly, in terms of looking at community interventions, there's debate still on what extent task shifting can be done. There are regions globally that have allowed community health volunteers, for example, to undertake community treatment of common childhood illnesses. But of course, this comes with its own policy issues, policy concerns, which have led some regions to be quite hesitant in taking this up. Then the second level is the health facility level. And the health facility plays a very important role, as we might know that most of the maternal and newborn deaths occur at birth or within 24 hours of birth. And therefore, it is essential that we have both basic and comprehensive emergency obstetric and newborn care being provided at health facilities, and accessible and of the right coverage to be able to ensure that the mothers and newborns who need these services are able to benefit from them. Also, the health facility plays quite an important role, especially when you look at creating a linkage with the community level in terms of ensuring that there is a swift referral mechanism from the community level to the health facility level. So what does the evidence point in terms of what has worked at the health facility level? A range of interventions, including standardized or individualized social support programs, and also continuity of care along the continuum of care, that is throughout pregnancy, labor, and the postnatal period. These have shown to have to improve a range of perinatal, maternal, and labor-specific indicators. Also, stress management trainings, multidisciplinary meetings, and feedback sessions have also been shown to reduce work-related stress and improve performance among healthcare workers. Just also to point at this juncture that most of the evidence that relates to the health facility level, most of it has, if you look at the existing literature, most of this has been gathered from developing countries. And therefore, as I shall point out later on in my presentation, there is need to be able to come up with evidence that is contextualized to developing countries. And this probably, once we are able to do this, it might be able to bring out more interventions that actually show promising results. Then key issues for further discussion around this area, quite a number of them, but I'll just go through them quite fast. I've mentioned about evidence, most of the evidence being from high resource settings. There's also need to look at the urban-rural discrepancy within countries. Looking at evaluating interventions using quality maternal health indicators. Then indicators of quality of care that need to be standardized to facilitate the evaluation of quality improvement efforts, as well as strengthening of health systems in order to be able to undertake evaluation of these interventions and how effective they are. We also need to look at the current efforts to improve quality of care, health outcomes in developing countries, in terms of them having a very strong evaluation component that can contribute to the current evidence-based. And then lastly, discussions around use of mixed methods approaches to evaluation, which can increase the depth of understanding and bring out contextualized barriers and supporting factors, especially when looking at scaling up of some of these best practices. Then the last level that I'll look at is the district level interventions. And the district level plays quite a unique role in that it is the first point, the first level of outpatient care and referrals for more specialized care. And it also serves as a nexus between the community and the facility level. And also it is at this point that training of healthcare workers, which is very critical, and also guidance to national health policy. It is at this level that such functions are undertaken. So looking at the evidence, use of directed financial strategies to increase service utilization, it has shown quite promising results, especially in terms of conditional cash transfers to be able to boost services like antenatal care and skilled birth attendance. Other regions that have implemented voucher schemes have also shown quite positive impact on antenatal care, skilled attendance at birth, and also postnatal care. And lastly, supervision of healthcare workers and service delivery has been shown to positively influence providers' practice, knowledge, and awareness. But to point out a critical challenge in terms of the evidence of what works at this level, at the district level, is that so far there's very little evidence to make a conclusion on the effectiveness of the district level inputs to improve maternal outcomes. So as I conclude this presentation, key issues come up. First is in terms of being able to refocus our efforts to looking at the quality of care. Because I think in the Millennium Development Goal era, much of the focus was on access and coverage of maternal and newborn health services. Less focus was provided or was given to the quality of care that is provided to mothers and newborns. And this might be the reason why, regions like Sub-Saharan Africa did not make, although they did experience a reduction in maternal and newborn deaths, the reduction was not as much as it was expected. So we are looking or going forward, I think it's important for discussions to be held around how proven interventions can be sustained and scaled up. And I think just tying into this is the aspect of being able to generate evidence in much of the developing countries, so that we are able to get more context-specific proven interventions that can be tried out and that can be scaled up. Then secondly, of the three levels that I've mentioned, that is the community, the health facility, and the district level, much less is known about the combination of strategies or interventions that work at the different levels. Going through my presentation, you'll have realized that I've mentioned a number of interventions that have been shown to work at the different levels. But the remaining question then is what combination of these interventions actually will lead to a greater impact. I think I'll end my presentation at that point. Thank you very much.
Edwin, thank you so much for your excellent presentation. It's clearly particularly important to consider how to scale up some of these small initiatives, and I think your presentation very comprehensively explored some of those avenues, so thank you for that.
Thank you.
To our listeners, please remember you can submit your questions at any point through the GoToWebinar question box. Please do send these in, and as mentioned, we will go through them at the end of both presentations. So Edwin, I'm going to put you back on mute now until we've completed all the presentations, and then we would take questions for you. And John, if you're there, I will just unmute you and give you control of my screen. So bear with me.
Okay, first of all, I want to thank you for inviting me for this webinar, and I'm ready. Rather, I'm happy also to contribute what I know in this topic, and I'm also saying hello to the listeners. First of all, I'm going to discuss some of the terms, definition and terms like maternal death, a woman's death related to pregnancy, birth, and up to the first 6 weeks after birth. Also, maternal and neonatal health are closely related, and the latter is dependent on the former. That means that we cannot discuss maternal deaths or rather maternal health without talking about the neonatal health, because the neonate only depends on the mother's health. The other definition is we're going to discuss is maternal mortality ratio, which means number of maternal deaths per 100,000 live births. Yeah, and according to the discussion that we're trying to reduce, or rather to go by the Sustainable Development Goals, the ones we are targeting mainly on maternal and neonatal health by 2020 is goal number 3, which states that we are ensuring healthy lives, promote well-being for all at all ages. 3.1 will work on reducing global maternal mortality ratio to less than 70 per 100,000 live births. 3.2, end preventable deaths of newborns and children under 5 years of age, and reduce neonatal mortality per 1,000 births. And then 3.7 is ensure universal access to sexual and reproductive health care services, including family planning, information and education, and integration of reproductive health into national strategies and programs. Next slide. Okay. Goal number 5, which is to achieve gender equality and empower all women and girls, also forms part of this maternal and neonatal health targets. 5.1 will be eliminate all forms of violence against women and girls. Number 5.3 is eliminate harmful traditional practices, specifically mentioning child marriages and FGM, female genital mutilation. And 5.6, ensure universal access to sexual and reproductive health and reproductive rights as per the NCPD program of action. So basically, those are the ones we are looking at when we are at the same time, we should be able to look at what will cause this maternal mortality, and of course, related closely is the neonatal mortality and morbidity. And in Africa, the big 5 causes of maternal deaths is postpartum hemorrhage, unsafe abortion, obstructed labor, fetal sepsis, and hypertensive disease, that's PET and eclampsia. Yeah, so according to the webinar's objectives, some of the strategies applying to reduce maternal and neonatal morbidity and mortality is 1, improve access to basic provisions, and then utilizing emergency technologies or utilizing emerging technologies. That is what I'm going to zero in on, and we will start with the first one, which is improving access to basic provisions. So we look at the first strategy, which is improving access to basic provisions, and probably in my recollection, we think that for healthcare, what are the basic provisions? One of them is good nutrition. Specifically, these are provisions which target maternal health. Then access to contraception. And of course, that one will tell us a lot because one should be able to have the number of children they want and at what intervals. Then skilled attendance at the delivery is very important, because this is where now we're going to look at some of the complications one can get during delivery. And then emergency obstetric care is very vital. And right to quality health care, including reproductive health services, that one is also very important. What are some of the interventions then, if we are looking at for us to achieve these provisions? One of them is appropriate financing, of because most of the African countries, the target is 15% of the national budget. Then health insurance for all, that would help women to access medical services when they are expectant. There are some countries also which are giving free health services. For example, South Africa and Ethiopia and Kenya also. Training of healthcare is very important because we are talking about skilled deliveries. Improve infrastructure, for example, theaters. There's some facilities which do not have proper theaters, and when women have obstructed labor, they need to be operated. Subsidized commodities like family planning and contraception, that one is important. We should also have good health policies, especially good reproductive health policies, like something like method mates. We have a previous presenter talking about method mates of family planning commodities and other services, reproductive health services. We also have comprehensive post-abortion care in some countries, like in Tanzania and South Africa and Kenya. Focused antenatal care, this one is very vital. These are some of the policies that we are talking about. Contraceptive policy for adolescents is very important also. Policy on harmful traditional practices like early marriages and FGM. There are some countries in Africa which have already banned FGM, some of them Kenya and Uganda. HIV policy is very important, especially in mother-child transmission and prevention of and management of PPH, as the use of misoprostol or oxytocin. I think sometimes also the quality of obstetric care and delivery is a good intervention. As far as the technologies is concerned, I think this is an area where this is quite useful because the applications is something one can download from the App Store or Play Store and then access information, and where they can also access this service. The other area of mobile technology is SMS. And the typical one is M for reproductive health. Yeah, and this FHI 360 Kenya and Tanzania they have launched this project mainly to give information, family planning information. There's also the Mama program in South Africa, which integrates maternal and neonatal health, and it gives very useful information to those who are prescribed to this platform. So basically, the mobile technology, I've just given 2 examples, but these mobile technology is an emerging technology with information to both the youth and the young mothers and even pregnant mothers, people who are expectant, so that their health is of high standard. The next technology which I would like to mention here is about drones, which is being used in Rwanda to deliver blood products. And this one, of course, reduces time taken to deliver urgent medical supplies. And the other issue is the internet, of course. There is a lot of information on websites, hotlines, and the search engines. And that means a woman, or rather anyone can search any question in the internet, either Google or any other search engines, and get the answer and get the information where they can get these health services.
Hi, John. Thank you so much for your fantastic presentation there. I know from our conversations you've had an extensive career in lobbying for improved care in this area, and it's particularly interesting to hear your take on innovative new approaches and looking at those emerging technologies. So thank you for your contribution. Unfortunately, the audio quality at some points wasn't so clear. So to our listeners, if anyone has any questions they wanted to clarify with John, then please send them to us and we will pass them on. But for now, I'd love to move on to questions. We've had a lot of people getting in touch. So John and Edwin, I will pass some questions over to you. Firstly, Edwin, we have a question for you. I know you mentioned a few times interventions at 3 different levels, so community, health facility, and district. The question is, in your opinion, what is the most important level to focus our efforts on if we are to achieve the maternal and newborn targets as set out in SDG 3?
Thank you so much for that question. Looking at the 3 levels, that is the community, the health facility, and the district level, each has its own important role to play. And one can't really say, or we can't really put an attribute to say that there's one that is more important than the other. The most important aspect or component to look at is how the 3 levels interlink with each other to work together as a system, because at the end of the day, those 3 levels form part of the health system. So I think key in looking at the 3 levels is being able to understand how they interlink with each other. And I think looking at the evidence that exists out there currently, as I mentioned during my presentation, there isn't much evidence or research or evaluation that has been done looking at how the 3 levels are able to link with each other, and also how the interventions at the different levels, what is the best combination of interventions that can lead to greater impact for women and children. Thank you.
Thank you, Edwin. That's a very comprehensive answer. We have another question for you that has been sent in by a representative from the Department of Health over in the US. And they're asking if you could please expand on the social support program that you mentioned and provide a brief outline of which activities were involved.
The social support programs for under the community, or I'm assuming he's talking about the women support groups?
Yes, I think that's correct.
Yes, so I mean, the women support groups are basically a community support groups, especially for women, where women, for example, who are attending antenatal care from the same community are able to form a support group. And through this support group, they are able to meet in the community, be able to share, they're able to share health messages, key messages. They're also able to share experiences. And normally the group is a mixture of individuals in the sense that we'll have those women who are expectant for the first time. Then we'll have the women that have gone through it before, and therefore it's a learning. It's kind of like a learning group where women are able to share experiences and able to encourage each other. There are programs, for example, that are being piloted to offer group antenatal care. So instead of giving the individualized antenatal care at the health facility as we know it, the service is given to a group of women who have come in for that service, and they're able to continue with that kind of support group into the community. We also have programs that are running support groups, for example, for breastfeeding mothers or lactating mothers. Again, this is just to be able to encourage, to form as a social support network for mothers in the community, to be able to ensure that first of all, they carry on with exclusive breastfeeding for the first 6 months. And from there on, with the introduction of complementary feeding, they're able to introduce the right nutritious feeds to their children. Thank you.
Thank you, Edwin. And just following up on that point, we've had another question from Albert over in Kenya. I think you've briefly covered this, but with respect to some of these community strategies, Are there any documented incentive systems that are worth considering?
Yes, there are documented incentive systems, especially if you look at countries like Ethiopia, the community health volunteer system in Ethiopia. If you look at the community health volunteer system in countries like Nepal, and also Kenya at the moment is really trying in terms of giving incentives to community health volunteers. But I think what is lacking at the moment is, first of all, critical evidence to be able to show the impact of these incentives, because if you look at most of these programs, like in Ethiopia, in Nepal, in Kenya, and also in the region, like in Tanzania, when we talk about incentives, most people tend to think of it in terms of financial remuneration. But critically looking at it, and also looking at the experience of community programs, incentives to community health volunteers actually go beyond the financial component of it. So, for example, training in itself, training of community health volunteers is an incentive in itself. Being able to provide them with the necessary tools to aid them in their work is an incentive in itself. The recognition that they receive from the community that they come from, that recognition in itself is an incentive. Their linkage with the health facility, so that the health facility is able to appreciate the work that they do in the community and be able to assist them in ensuring that they meet their objectives in the community, is an incentive in itself. So there is that lack of evaluation of most of these community volunteer programs in terms of the impact of the incentives, and also what kind of incentives actually work. Thank you.
Thank you, Edwin. It's interesting to rethink our understanding of what incentives can be offered. So thank you for that. Just a quick reminder to our listeners, please continue to submit your questions, and please let us know which panelists you would like to ask them to, so we know who to pass them on to. John, we will move on to a few questions we have for you. So firstly, on the regulatory and policy side, how do you feel sound reproductive health policies will affect maternal and neonatal mortality in Africa?
Well, I think this is something which actually has not been dealt with by most of the countries. But if you look at some of the policies that some countries have produced, and they have become very effective. For example, I can mention two countries which have had policies on comprehensive abortion care, like in South Africa and Ethiopia. You find that most of the complications from abortion have really reduced drastically, and I'm not actually supporting policies like those ones to allow women to access either comprehensive post-abortion care or comprehensive abortion care. Another area where the policy has really helped is in the area of HIV, because the maternal to child transmission has actually diminished quite strongly, because women who have been found to be positive have taken antiretroviral medicine during pregnancy, and the baby also having been given some medicine after birth, and this one has reduced transmission of HIV from mother to child. Another area where the policy has worked is where governments have stuck on a policy of stopping early marriages or even female genital mutilation, because female genital mutilation has been found to cause obstructed the pathway, and therefore women get complications during birth, and they can easily have ruptured uterus, etc., if they cannot access hospital where the circumcision incision can be expanded. So the issue of traditional practices is something which is quite sound also. Another area which has helped to reduce maternal morbidity and mortality is focused antenatal care, whereby the health workers or other women have been told at least to visit antenatal clinic at least 4 times during the gestational period, so that at least some of the problems can be discovered and dealt with. We also have the emergency obstetric care, which is being practiced by some governments, and to make sure that women who are undergoing delivery are attended by a skilled provider, and some of the areas like use of misoprostol and or oxytocin, just to make sure that to prevent PPH. These are some of the areas that we make sure that when the woman is in labor, the policy of emergency obstetric care has to be trained to service providers, and then of course that will reduce some of the complications like PPH. Thank you.
Thank you, John, for your answer there. And sticking on the topic of policy, we have a question from Akil from Pakistan. He's keen to understand your take on how to implement contraceptive policy in areas where it can be very sensitive to discuss.
Maybe I can comment about the contraceptive policy, especially among the youth. This is an area whereby some countries don't encourage youth to use contraception because they feel that the youth have no families to plan, and therefore they should not be allowed to use contraception. But there are some countries which have got sound reproductive health policies touching on contraception, and they state that as long as the youth or the young person is sexually active, then they should be able to allow to use contraception. And if possible, you start youth-friendly centers or youth-friendly services whereby the youth can access those centers themselves without mixing with the parents or with the other people who are married. And this is a youth-friendly services is one of the areas, one of the policies that I can see some governments have been able to implement, and these young people have been able to access contraception.
Thank you, John, for that. And just moving on to the second part of your presentation, looking at those emerging technologies, we have a question from Freddie. Freddie asks, John, how can we ensure the sustainability of emerging technologies if the initiative is not government-led? And Freddie's from Village Reach DRC.
Well, I think what I feel is that most of the, like mHealth, the mobile technology health, this one is can be sustainable because most of the population, I'm sure even in Congo, at least 80% of the people have got mobile phones these days, and it is the technology that we are using is just SMS, which can actually be accessed or be accessed by anybody, a mobile phone, and some of these programs are donor supported. I feel that the way using this mobile technology and the initiatives, I feel that once you start this project, they push you to enjoy the.
John, unfortunately, we seem to be having some trouble in hearing you clearly. So we'll just move back on to Edwin and follow up afterwards. So just to our listeners, we will be doing a write-up of some of the key takeaways, including the question and answers. So if there are any points that you haven't managed to catch, don't worry, we will be providing a comprehensive summary. So Edwin, just back to you while we look at the audio for John. We have a question from Islam from Pakistan. And he asks, with the high cost of healthcare being a major factor which forbids mothers to go to hospital, how can this be rationalized?
Thank you for that question from Aslam in Pakistan. Yes, the high cost of healthcare is definitely a big barrier and challenge to access of quality maternal and newborn health. But I am happy that, if you look at the Sustainable Development Goals, Goal 3, under it, universal health coverage is one of the key pillars under it. And there are various, looking across the developing world, there are various approaches that both government and non-governmental organizations and international organizations have tried to address the cost barrier. One of them is in terms of being able to subsidize essential health services. So especially looking at services that are provided to mothers and children under 5 years. So if I can just give an example of Kenya, in 2013, the government came up with a policy to make maternal health care free at all public health facilities, and there are also plans to extend these to select private facilities, especially the faith-based health hospitals. So there is the approach of government being able to subsidize some of these services. Secondly, we have insurance schemes that have been used also in the developing countries, where mothers are able to enroll on an insurance scheme so that by the time they go to seek the services, then the services that can be fully paid for by the insurance scheme. So for example, again in Kenya, we have what we call the National Health Insurance Fund that has now come on board to be able to ensure that there's provision of free maternity services to mothers. So mothers make a monthly contribution to the scheme. There are also other schemes that are being tried by non-governmental organizations, for example, using mobile technology. Now that, like Nyamu, the other presenter, has mentioned, how technology can be used to increase access to healthcare. So mothers are able to save some money on their mobile phone, and so that by the time it comes to delivery, they are able to pay. They are able to pay for the services. So those are some of the approaches that have been used. We have countries, again, for example, that have come up with community schemes or community pooling of resources to be able to ensure access to health services. We have countries that have come up, that have employed the strategy of public-private partnership, so that services, for example, services that the government cannot be able to provide at its hospitals, these services can be accessed at private hospitals, either at a subsidized rate or the government fully pays for them. Thank you.
Thank you, Edwin. The examples that you gave from Kenya there were particularly informative. And we have one more question for you, and then we will go back to John, who seems to have re-established his internet connection. So, Edwin, just one more question for you from Janet from Switzerland. Janet asks, while increasing breastfeeding initiation rates is stipulated in the SDGs, what do you feel would be essential to help achieve this, and which organisations can you work with to move towards this goal?
Yes, thank you for that question from Janet in Switzerland. I would look at it from basically three levels. Starting with the at the policy level, I think it's critical that countries are able to enact policies that are friendly in terms of ensuring breastfeeding initiation and being able to sustain that. And one of these, alongside these policies, is the being able, for example, again, if I can just give examples of some countries that we have examples of countries, for example, that have outlawed giving milk supplements to infants. So policy, a favorable policy environment, I think is very key in achieving this. It makes sure that there's an enabling environment in which good breastfeeding practices can be rolled out to communities. Then the second level that I would look at is in terms of the service provision at the health facility at hospitals. One strategy that is widely used and widely recognized is the baby-friendly hospital initiative. And basically, this is an initiative. It has 10 steps that facilities should fulfill for them to be termed as baby-friendly. Some of these steps, border around making sure that mothers are able to receive appropriate breastfeeding guidance, especially when they come for their antenatal visits. That we have appropriate breastfeeding messaging at health facilities that mothers can be able to access. Also, ensuring that mothers are guided to be able to initiate breastfeeding within the first hour of giving birth. So if we can be able to target to ensure that all hospitals are baby friendly, then this can go a long way in increasing the initiation rate for breastfeeding. Then lastly, I would look at it from the community level, the community component. And in this, again, we have a widely recognized strategy called the Baby Friendly Community Initiative. Again, it's just ensuring that there's proper community sensitization, proper community awareness about the benefits of breastfeeding, the appropriate time to initiate breastfeeding for mothers. So if we can be able to focus at these three levels, ensuring that there is the correct policy environment, that hospitals that provide service to mothers are baby friendly, and that there is community sensitization of good coverage, and that mothers are able to understand the benefits of breastfeeding, then I think we should be able to see a significant improvement in the initiation rates. Thank you.
Thank you, Edwin, for that comprehensive response there. We have a lot of questions coming in, but I am conscious of time, so we will move on to the final question. John, if you're there, this is a question for you. So the question has come via Twitter from Donor Zone. I think John seems to have lost internet connection again. So to Donor Zone, we will pass on your question to John and get back to you. Thank you very much for sharing that. As mentioned, we will also be doing a write-up, so all of these extra questions will be answered. So I think that rounds off the questions. I want to say a final thank you to our speakers and all participants for joining the webinar. If you're interested in learning more on these important issues, please register for our event in Nairobi on the events tab on our website. We hope to see as many as possible of you in just 3 weeks' time at the Safari Park Hotel, where we will follow up on many of these questions and more. Thank you.